We know that breast cancer is not a single disease. We've just been talking about that. Today, we don't treat breast cancer, as it's all the same, and we do it based on biology and stage. So, if one state size does not fit all for treatment, why should we screen as if everyone has the same risk for the same breast cancer? Across the world, there have been so much controversy and variation in guidelines. In the United States, there are 7 different guidelines. There have been years of disagreement on how often to screen and when to start. I'm very pleased to be able to present the exciting results of the Wisdom study, our risk based approach to screening. And on behalf of my colleagues and the entire team who carried out this study, uh, I think it's very apt that Michael showed this tower that you can build upon because the Wisdom is a platform trial, and at the end, I'll tell you a little bit about what's next because this is our first comprehensive idea of starting with risk is really what we are interested in building upon and making better. So we know that breast cancer is not a single disease. We've just been talking about that. Today, we don't treat breast cancer, as it's all the same, and we do it based on biology and stage. So if one state size does not fit all for treatment, why should we screen as if everyone has the same risk for the same breast cancer? And across the world, there have been so much controversy and variation in guidelines. In the United States, there are 7 different guidelines. There have been years of disagreement on how often to screen and when to start. The United States is the only one that has an annual screening starting at 40, although Sweden has 45. And interestingly, this disagreement is over the same randomized data generated 25 years ago. So, why improve screening? Well, truly, we have to do a better job of finding fast growing tumors early. We wouldn't have trials like ISPY and other neoadjuvant trials if screening was perfect. Um, we want to reduce the burden of screening. There's lots of callbacks, false positives, diagnosis of DCIS. 50% of women get called back after screening for 10 years. And, again, about 50% of women still find their own cancers today because they grow in between or they grow at young ages. So we have to really think about how can we do it better. And that might be that we should personalize recommendations based on comprehensive risks, which it allows us to think about age, race, breast density, genetics. And I think we want to put in perspective what has been one of the criticism, although screening, yes, finding cancer early is really important. We also have to be aware of some of the downsides of screening. And the big criticism of screening has been this big increase in early stage cancer without seeing a concomitant drop in late stage cancer with the concern of finding indolent cancers that might not surface and leading to overdiagnosis and overtreatment. So keep that in mind when you see the results of this study. So Wisdom, Women Informed to Screen Depending on Measures of Risk, was designed to make screening better. And that is using a modern foundation, integrating risk assessment to then guide screening and prevention. So with the modern era trial, allowing women to join regardless of where they get their care, doing it virtually, test a strategy where everyone is not screened the same, and establish a personalized approach to improve the identification of women at risk for aggressive or more interval cancers. This started as an initiative of the 5 University of California breast cancer campuses at the medical centers across the University of California facilities, and we added sites, University of Chicago, Alabama, the VA, and Topline Health in Florida and in Texas to try and improve the diversity of the patients that we accrued. This was a pragmatic trial. It was funded by the Patient-Centered Outcomes Research Initiative, and they were looking for pragmatic trials. And this was open to women 40 to 74 with no history of breast cancer. So again, it's important to keep in mind we didn't have people come into official sites to come in and get, they had to do self-reports. It was really very practical. So we did 2 things. We asked women to be randomized, but we recognize that all women don't want to be randomized. And if you don't ask what happens to the women who won't be randomized, you have no idea what your biases might be. So, if people are willing to be randomized, you know that they're at equipoise and they're not sure which is better. So we asked first to be randomized and then allowed people to join and self-select so we could understand what their preferences were. There was a lot of thought that no one would ever do anything other than annual screening in the US. It turns out not to be true. Uh, we used a comprehensive risk assessment model. At the time, we used the Breast Cancer Surveillance Consortium version 2, which takes into account age, race, ethnicity, family history, biopsy history, and breast density as measured by BI-RADS on clinical by the radiologists. And it was a model, BCSC was validated on 1,000,000 women across the United States, which is where the study was conducted. We sequenced the 9 breast cancer genes that are at risk. And we also, again, uh, did germline testing and looked for the single nucleotide polymorphisms, the small variations in the many genes that you inherit. And is that science has continued to increase to be together. The polygenic risk score was used as found by the BCAT consortium and so on. We continue to improve it every year as data continue to emerge. We then use this information to develop a tailored screening and prevention plan about the age to start, when to stop, frequency of screening, screening modality, and then importantly, how to reduce risk. So, with this information, with the breast density health questionnaire and the genomic profiling, we then identified 4 categories. The lowest risk, where there was no screening until age 50 or until that you developed a 5-year risk of 1.3, which is the average risk for a 50-year-old. 1.3% average risk. Women were assigned biennial screening every other year, mammograms. Elevated risk were given annual mammograms, and the highest risk were given annual mammograms alternating with an MRI, so 6 months, screening something every 6 months. People in that highest risk category were assigned a breast health specialist who reached out to counsel people on risk reduction using a breast health decisions tool. All of the pathogenic variants were assigned to this highest risk or the elevated risk, depending if you had the high penetrance genes were in the highest risk and the others were in the elevated risk group. Breast health decisions tool helped to show people that could look and understand each risk factor, could understand how we constructed the risk, and then what people could do to lower their risk. And we showed people risk in context using tools for shared decision making to put risk in context. What were the study questions? Was it safe? Would it reduce biopsies and false positives? Would it encourage prevention in the highest risk women? Would women accept it? Would people be willing to randomize, and would they choose it if they were given the option? And would it provide value in terms of reducing overall outcomes at lower cost individuals in society? Primary endpoint was the rate of stage 2B or higher cancers. They had to be non-inferior in the risk-based arm. People were very concerned. Radiology community was concerned that we would increase by lowering the amount of screening in certain people, that we would increase the chance of finding stage 2B cancers. So we set there had to be less than 1 additional stage 2B or higher cancer for every 2,000 women screened. And we wanted to see, hopefully, that the rate of biopsies would be lower in the risk-based versus the annual arm. So what were the results? Here's the consort diagram. Women learned about the study online. They registered online. They were invited to choose randomized or observational and consented online. 61% agreed to be randomized, showing that there was equipoise. This is very consistent over the entire study, over 7 years. And those who declined randomization and chose their arm, in that case, 89% chose risk-based screening, regardless of age, regardless of geography, regardless of race, ethnicity, or anything. That was also very consistent. Small differences in some of the choices, but very consistent. So if you look at this, there were 2% of women who were in that highest risk group. You really had to have 6% 5-year risk, and that really was a lifetime risk higher than 40%. Elevated risk was the women in the top 2.5% of risk who had about a lifetime risk in the 25 to 30% risk. The average risk were those in between up until that average screening risk of 1.3%. So 62% in that group and 26% in the lowest risk group, and 75% of women in their 40s were told not to screen until 50. And then against the annual arm, note that there were only 10% of women in those high risk categories. Women came from all 50 states. You can see at our screening sites it was highest. Here's the primary endpoint. This blue line is the non-inferiority margin. We were nowhere near close. And you can see the superiority. We were lower than the superior and past that superiority with the ends just barely crossing that superiority. And I'm going to show you now what this looks like in the cumulative risk, where you can see here, this is the people who are screened annually. And you can see that there's a significantly lower here amount cumulative uh, cancers of stage 2B or higher cancers in the risk-based arm. But importantly, there's another really fantastic finding, and that is in that highest risk group who are told to screen every 6 months, there were no stage 2B or higher cancers. And here you can see in the elevated group, there were still, that's where we had the highest ones. We'll have to work on trying to figure out who those people are and work on seeing who should move into the highest risk group for more frequent screening. There's your average, there's your lowest risk group, and that compares to the annual arm average there in that dotted line. The number of cancers in each group were the same. And you can see if you include all of the cancers, there were the most cancers and the highest risk group. So you can see how well this stratified the risk. This was our first attempt at comprehensive risk, the highest risk, elevated risk, average risk, and lowest risk, and then with the annual arm in the dotted line. Now, trying to address that issue about did we have a lot more early stage cancers without a concomitant drop in stage 2B cancers, here you can see that in the risk-based arm, we did have a higher early stage cancer, but we did it, but also with a concomitant drop in lower risk cancers. You can see this now here. Here, you'll watch this go up with this concomitantly going down by about the same amount. And so that really shows that we really were getting the right people in, and that was the whole goal. The radiology community was also concerned that we would increase the rates of stage 2A cancers by allowing some people to screen less. But it turns out if you're judicious about who you screen, that is not going to happen. You still do see that the rates are highest in the highest risk group, and then the elevated, average, and lowest risk group. So this is really important finding that we do actually do a good job of stratifying risk compared to the annual arm. The biopsies were similar in both groups, but they varied very much by risk. You see, again, the highest risk here. We were disappointed, but some of that I'll go over in the limitations. There were definitely fewer mammograms, and you can see there are fewer mammograms by group, but some of that was similar, and that was we didn't do as good a job in getting people to believe in moving to following all of the recommendations, and there's a lot of pressure in the US for everyone to screen every year. I think it's also important people says, is it feasible to do germline testing of the population? And we did it without increasing anxiety, which we studied. I don't have time to go into that, but 75% of the women who were assigned genetic testing completed their genetic testing, spit kits sent to people's homes. We only counseled the people who had pathogenic variants, and we were able to find over 95% of women. But very importantly, we found 3.1% of women with pathogenic mutations. Not a lot, but you can see these made up over half the women in those high-risk groups, including 1.2% of those high penetrance mutations. 30% of those people had no family history. That's so important. And this is published in JAMA Oncology with Fergus et al. And we just showed actually at ASCO, does it really matter to find the pathogenic variants? You have to do the germline testing and look for the BRCA1s and BRCA2s, does that matter? Well, it turns out that, yes, it really does matter. This is 65% of the patients, and without that pathogenic variant status, these women, only 1% would have been assigned to more intensive screening. And actually, the women who are young would have been told not to screen until 50. So I think that if you had very limited resources and you were going to do only one thing, finding the people at the very highest risk would be the most important thing. It's a one-time test and it's cheaper than a mammogram today. The uptake of prevention interventions, it definitely increased in the highest risk women. We actually are now working to get this information more intensely, especially with the advent of low dose tamoxifen, which is much better. We also had the majority of our people who are in this group said they increase their exercise, reduce their body weight, and decrease their alcohol intake. The limitations were, of course, that not everyone followed their assignments. People get their information from many sources, and including annual recommendations from mammography centers. And I think the results of wisdom will provide confidence now going forward to follow guidance. We did not engage directly with the primary care physicians, and that's something that we're working on, is to integrate our recommendations into the medical record. It was pragmatic. We used self-report, but we actually verified more than 95% of all the cancers with imaging and pathology reports, and the registry linkages we did yielded very few additional cancers, and the number of biopsies reported were actually 4 times higher than the number of cancers, which is fit the expected cancer biopsy rate. So actually pretty good. And we did, in a couple of centers, verify that it was actually the over 90% was the self-report, which is great. Tracking adherence, however, is challenging. We're starting a new imaging repository in Wisdom 2.0, and that will make it better. So you may ask, can we afford these new approaches? Is that feasible cost-wise? Well, it actually turns out that concentrating more resources on those at highest risk is very cost-effective. There's a fourfold cost difference among the screening guidelines in the U.S. This is the American College of Radiologists, this is the United States Preventive Services Task Force, and this is Wisdom, and this is a modeling approach. And that paper is has just been submitted for publication. So, in summary, I would say that, you know, this is the reason we picked the stage 2B cancers. This is where you start to see the big difference in survival. But in the US, you know, there are about 46,000 stage 2B or higher cancers. We dropped that rate by a third. So if we could do that, we had the potential to perhaps save 4 to 5,000 breast to reduce the breast cancer deaths by 4 to 5,000 a year at a projected lower cost and a lower screening burden for those at lower risk. That's for millions of women. So I think this is the beginning, not the end. I think risk-based screening should become the new standard of care. Then more for those that need it, less for those who do not. There's nothing that about breast cancer that makes it unique. For colon cancer, I would say the same. For lung cancer, I would say the same. These are smarter approaches. Now that we know more, this is what we should be doing. And I also say that, I like to do platform trials, and Wisdom provides a framework to continue to improve. We have Wisdom 2.0 underway. We already have 35,000 women enrolled. And the idea of we're trying to predict fast versus slow growing cancers. We now do low pass whole genome. So we've just finished implementing a predictor for triple negative breast cancer for African American women and for white women. I think, again, each country or groups, as we start to learn how to do this, we can really help to really adjust screening all over the world so that it will be better. We are working by the end of the year to have mammographic AI in. I think it will reduce the overuse of contrast imaging. Instead of the 50% of people who have dense breast tissue, by using mammographic AI, you can find the 10% of people that might need additional screening. And we want to focus on implementation and prevention. So with that, I would just like to say that this takes a village. There's a huge number of people who are involved in this all over the country, and we thank all our funders, especially PCORI, the NCI, and Breast Cancer the Breast Cancer Research Foundation and Quantum Leap Healthcare. And takes a village to do all this hard work. Thank you so much to all the study participants who are continued to be devoted and report their results. And thank you all for your attention. I so appreciate the opportunity to present our results.